This is my client Cher, who is a massage therapist. And on her first visit, we had some asymmetry of her pelvis with reduced motion with respect to passive spring tests. Now today, she no longer presents with that pattern, basically what we name a posterior ilium on the left and what we name an anterior ilium on the right. Now when she lies on her back, she still has asymmetry of the pelvis, but she has normal mobility with spring testing. And so I think that at the factory, she developed a discernible asymmetry of the anterior landmarks of her pelvis. When I compare the posterior landmarks, they seem quite symmetrical. And of course my vision is going to be, I won't capture the subtleties of several millimeters, but the pelvis looks much more symmetrical and prone than it does in supine. Now what I'm doing now is focusing on the lower pelvis, and this is a pattern I stumbled on a long time ago, which I call lower windswept pelvis. And some people have this pattern, but they have normal mobility. And when I encounter someone with this pattern, but they have blocked movement, then that's usually a treatable pattern. Now the midline crease of her clothing matches the midline crease of her buttocks. And when I put my medial finger just medial to the ischial tuberosity on the right, you'll notice it's quite close to this midline crease on her clothing. When I put my thumb inside the ischial tuberosity on the left, you'll notice there's quite a distance there to the midline of her clothing, and that midline is I've already tested it, is congruent with her buttock. So now we're going to do the mobility testing. And the slack is taken up very quickly, or maybe it's already taken up, but I cannot get any spring mobility going lateral to medial. When I encompass the medial aspect of the right ischium, there's no spring mobility. Now if I put 50 pounds of force, I would override the pelvis and the whole pelvis would move. But that's not what we're looking at. We're isolating a specific spring mobility, and I'm using approximately 15 to 20 pounds of force to take up the slack. And in a normal population, that would induce movement. And the spring mobility would look something like this. So here I've taken up the slack, and now I can spring it. And I can see the movement go through her body, and I can see her head bob up and down. Going right to left, I can take up the slack, and it takes up quickly, so that's a hint that it might not move. And so I've got 15, 20 pounds of force, and now I'm doubling that force and trying to get some spring mobility, and there's no give. So then I come onto this side, and I try and take up the slack, and it just doesn't move very much at all. And now I'm doubling that force, and there's no give. So I'm calling this a lower windswept pelvis. And sometimes this pattern encompasses 6 things. And one is the lateral positioning on the left and the medial positioning on the right, but also a rotational element in which the right hip has greater internal rotation, reduced external. The opposite on the right side, where the right side has greater external rotation and reduced internal. Did I say that wrong? I'll show you in the treatment, and I'll clarify that in case I made a boo-boo. This pattern also typically includes a posterior rotation of the left lower pubic bone, and we screened her a while ago. There was no such finding, so we don't need to treat that. The other thing this pattern correlates with is a side bent coccyx. Now we treated her for a left side bent coccyx last session, and she does not present with that today. So the treatment that I'm going to do is, and I believe that this pattern might involve the SI joint and pubic joint, but it's very difficult in the clinic to actually measure that specific movement. And asymmetry of the pelvis doesn't tell us anything about what's going on inside the sacroiliac joint. I know that. And reduced motion testing through the pelvis does not tell us anything about sacroiliac position. So what I'm suggesting that this has much to do with changes in hip mobility bilaterally and changes in positioning of the entire pelvis. So I'm skirting that sacroiliac conversation entirely. The way that I treat this is I stretch the right hip into abduction, and I do that for 2 minutes. Then I have the right hip, I have that stretch into internal rotation. I take the left hip and I stretch it very gently for 2 minutes into external rotation while stabilizing the pelvis. And then if you would please lie on your back. I stretch the left hip into abduction, and the way I do that is I cross the leg over, the right leg over, and then I stabilize that and bring the other leg into adduction and do that for 2 minutes. So I'm not going to film that treatment. It would bore you to tears to film 4 minutes, 2, 4, 6, 8 minutes of passive stretching, but that's how I treat it. And sometimes it fully resolves, restores movement and symmetry. Sometimes it doesn't. So I'll stop filming and we'll come back in 10 minutes.